Welcome back to GBA 2, Directing Benefit Programs Part 2. We're now in Module 3, Controlling Risk Factors. A little insight before we get into the material. We're going to be talking about insight on the effects of adverse risk selection. And that's all over the board. Risk selection from consumers picking what's best for them, not necessarily best for the self-funded trust or the insurance company. The risk selection that occurs when tragedy occurs, like a COVID pandemic, and people are rushing to get some coverage all of a sudden. And also the risk selection that occurs actually when insurance companies cherry pick healthy groups instead of groups that really need the coverage. So it's all over the board what it is. First, we'll look at some individual behaviors that's on there and adverse selection. And then we'll look at what I call the new lens of the holistic approach, even when insurance carriers are doing that same type of treatment. Now, some might say they're not carriers, even individuals don't do it intentionally. But be it intentional or unintentional, the bottom line is people may choose, for example, a health insurance plan, especially we see this with our seniors. They pick a plan because their wonder drug is on that plan. So that in a way is adverse selection when people make decisions what's best for them. Hey, nothing's wrong with that. No, don't get me wrong. But the fact is there is adverse selection intentionally or unintentionally. Yeah, I do see a lot of this with Medicare Advantage plans, especially where are people marketing those plans? Sometimes I see carriers with their representatives going to upscale senior living complexes, but I'm not seeing them go to the inner city. So the bottom line is now Medicare is saying, hey, wait a second, if you cherry picked the best, you might have to do a subsidize to those that didn't cherry pick. So we'll look at some of the issues that are out there and try to bring some equalization there so all people can have a fair shot at affordable health insurance. So we are going to explore some of these risk factors, and some of it does relate to possible public policy. And we'll see a lot of concepts in the reading on possible ways to in the future for our government to look at ways to mitigate the concern of some insurance companies saying, maybe I should need to pull out of this marketplace altogether. To maintain the solvency of the insurance carriers, perhaps the federal government can do a couple of techniques in the future, and the reading looks at some of those potential things that could be to come. This whole concept of adverse selection, it wasn't even on the agenda of adverse selection of the carrier is doing 10, 12 years ago. It has come to the limelight, and we'll be talking about a couple of potential solutions. And I hope it helps you as a professional grasp not only how premium rates globally are based and to relate to the risk status of a covered population, but how some equalization and fairness in premium can be put on the table. And as always, there'll be some provoking questions, some of which you can do on the discussion board if you wish to share. I sure encourage that. But let's proceed. Let's go with what we call Learning Objective 1, Predicting Individual Use of Health Services. Again, basically, there are 3 factors of predicting health service utilization. Prior utilization, which by far is the best predictor, is one of those 3 factors. The past does predict the future, especially the prior year. Health status, it's a good predictor. Now, granted, it can be a predictor, but it can't be a way that if you say, hey, I'm not healthy, you're denied coverage. Don't get me wrong. But it can be a predictor of what can be expected, what the carrier can be expected with the claims coming. Now, we're not going to individually deny anyone, no, but get a feel of what potential claims can come from the population. And then we have the demographic characteristics. That might be the weakest factor of them all. What's out there. But the whole concept is the value of predicting future healthcare utilization in patients is key because it can provide useful information to better understand and manage the overall health, the deliverables, the clinical resources needed, and admittedly, the potential of costs to the insurance carrier going forward. Predictive healthcare utilization. It actually was part of ACA. It's been around, and that the whole concept in that healthcare exchanges as well as the Medicare Advantage plans, they must risk adjust their enrollment. This is a concept we're going to revisit over and over again, not only in this module, but in our future modules. So what is risk adjustment for the purpose of setting health insurance premiums? Even in the most complete set of measures, we want to see that, let's say a small proportion of the variance in an individual's use of health insurance might be out there. Let's clarify. The risk adjustment methodology very much can directly determine premiums based on expected utilization of the group. We got to be very careful here, because if the health insurance utilization was wholly predictable in terms of timing and degree, wait a second, we don't need insurance. If everything's predictable, what do you need insurance for? You know what it'll be. And actually, insurance is obtained to protect you against the unpredictable. That's why entities get insurance. You buy for the unpredictable. How we've sometimes wavered from that, but that's the bottom line. Insurance is obtained to protect against the unpredictable. Now, there are some measures that are better predictors of health services than are others, but even a small predictor, even if it kind of can shave a little bit of bringing us to the reality of what it could be, it can be very cost effective and can help mitigate exposure and risk. So with all the statistical modeling, let's face it, there are going to be limits to gain predictive information on the future use of health services. And we got to look at, how close do we want to narrow the predictive nature of everything. We got to also look at the economies of scale. How fine-tuned do we really need to go? In Medicare, we see an interesting concept. It's called the Medicare Adjusted Average Per Capita Cost. It's also known as the AAPCC, and it's used to reimburse many of the Medicare Advantage plans. I'll refer to Medicare Advantages as the MA plans, Medicare Advantage. What I'd like to do is spend a moment to clarify Medicare Advantage. Some people call it Option C, Medicare Advantage, the choice plan. But the bottom line is when you have a Medicare Advantage plan, please understand it is not Medicare Supplement that supplements Medicare A, remember the hospital, B, the physician, nor is it a traditional supplement plan in any manner. Now, a participant in Medicare Advantage plan still has to pay the B premium, be it on a disability, unless they're Medicaid, pre-65 or post-65 for the health insurance plan. You still have to pay the B, and hopefully you qualify for the complementary A because of the service that one has given. So what happens as a review on Medicare Advantage plans get money from Medicare. The consumer's not going to send the claims to Medicare, A or B. They'll go straight to the Advantage carrier. But the Advantage carrier is getting money from Medicare A and B. Now, part of that whole reimbursement methodology that goes to the carrier for accepting the risk is the Medicare Adjusted Average Per Capita Cost, AAPCC. That's how much Medicare will spend in a year for an average beneficiary. It sometimes is referred to as a risk adjustment. So I want to clarify some of the key points that are so vital to understanding this. It's a method that is used, and many of the Medicare HMOs are following this model. So that's the system appears to have been providing even beyond that. Some HMOs said, hey, this is a pretty good concept there. Because there are incentives for enrolling people, though, And carriers are really saying, we like this concept, but Medicare is saying, yeah, if you want to go shop and take the good risks, we're going to put a factor to not necessarily give you an incentive to enroll the healthy groups, as I mentioned earlier. Actually, there'll be an incentive for enrolling people with lower than average expected claims and providing people with above average claims. What does this mean? We try to deviate from this model. So the existing model appears to have provided the private plans the incentive to enroll people and cherry pick. However, combating that, there are now some key factors in to kind of, no matter what group you pay, we get it at Medicare and we'll adjust the payment that you get to the carrier so you're not going to have an incentive to cherry pick. So go ahead, enroll the lower than average expected claims people because we will adjust the AAPCC method. So those with fewer health risk and fewer anticipated claims, historically were gravitating to private, mainly HMO plans, and what we call the CMP model, a generic term for competitive medical plans, although some brokers refer to it as comprehensive medical plans. But the bottom line there is now a adjustment factor put into place. Now, I made references to a couple of resources that are out there and terminology on that are available in the readings, but I want you to kind of get this whole concept is that there is now the opportunity to improve the AAPCC model to minimize the cherry picking by the by the insurance company. I call it the improving the AAPCC and looking at the measures of potential risk factors. Part of the RAND health insurance experiment and the RAND study objective looked at some of these concepts. They provided a method to look at the potential risk factors used. And if you look at the RAND health insurance experiment that's in the reading, the key takeaway was the notion that Medicare or even an HMO could improve the predictive model to reduce the costs. And at some point, we want to acknowledge that, you know what, that's not a fair advantage. We got to adjust it. At some point, the value of extreme predictive modeling, though, also might not be cost effective. Nevertheless, look at the chart that's in the reading, and you see the measures of potential risk factors used in the RAND study. And the related reading shows a good explanation of the variation in healthcare expenditures yielded by using just some slightly alternative specifications. It looks at the impact on copays on expenditures by looking at, in this case, it was 6 locations across the country, and it used some alternative predictive modeling of utilization based on demographics, subjective psychosociological measures of health status and prior utilization. It summarized those 6 major summaries of the RAND study, and it looked at the Newhouse study. You'll see in the columns, and admittedly, with the exception of the U.S. HMO study, known as the FOWL study, all the results were very similar, which is why health insurance focus on prior claims experience is so vital when setting insurance rates. The RAND study noted some various key issues, variables in risk factors. It said demographic measures, the AAPCC variables of age, gender, location. We can use that as a baseline. We had subjective health status measures, including physical health, mental health, general health, and disease count, and the psychosociological health status measures, such as the various measurement tools that are out there. But the key thing is to reemphasize prior utilization, looking at outpatient, inpatient expenditures was key. The RAND study findings showed prior utilization, when they added to the AAPCC demographic, it explained where are the total expenditures going? What is going for inpatient claims? How can we fine tune it? How can we really fine tune outpatient expenditures and have a takeaway that we have value here relative to other approaches, but we now have some explanations to where claims are predicted to go. Now, look at, in your reading, if you don't mind, in the textbook, some of the concepts, and I love the thought-provoking concepts that are especially by page 47. Now that brings us to a related point, the health payment methodology, including the Medicare reimbursement mechanisms. The Center for Medicare and Medicaid Services has a hierarchical condition category. It's also known as the CMS HCC. It's still relatively new for many, but let me give you a 2-point clean breakdown of it, of the aspects and the rationale. Since 1997, when the Balanced Budget Act came out, Medicare has been charged to better incorporate health status into its capitation charges, again, to minimize the cherry picking, and to reimburse Medicare Advantage plans via a risk-adjusted payment system. So how do you modify what we talked about a few moments ago? Basically, the BBA, the Balanced Budget Act, said we're going to require Medicare HMOs and other providers to give us encounter data and send it over to CMS, the Center for Medicare and Medicaid Services. We'll use that encounter data to better predict the quality of what's being rendered. And in theory, they can better prospectively estimate predictive costs for the Medicare Advantage beneficiaries. And they can adjust the Medicare capitation payment via modeling. So this whole process is the CMS HCC model, which assigns diagnosis to hierarchical medical condition categories. Now, slow down on this concept. It has some fallacies. One is when there's a pandemic, and we'll talk about this later, you don't have a lot of data because people kind of delay some of the elective things that really need to get done, but they postpone it partly because they can't get in. Hospitals are full treating people victimized by the pandemic. So you don't have a lot of good data in some cases coming off a pandemic flow. The other thing is with telemedicine, you don't get a lot of the coding and some is in. It might not be as accurate as we get in the face-to-face visit. So you do have some limitations on the predictive modeling that could become there. Now, there are 10 guiding principles of Medicare's risk-adjusted approach. They all relate to insurance underwriting issues, understanding acceptance by users, and safeguards, simply to get folks from gaming the system. It's a key list that I encourage you to look at in the text around page 56, 57 area. It brings us to the question of how is Medicare Advantage payments under the CMS HCC model determined? Well, first you got to get a local benchmark, a base rate, an average annual Medicare cost for a particular area. We multiply it by factors associated with the number of demographics and also with the member's medical diagnosis. So we have the Medicare Advantage payment. And then there is the bidding process of Medicare Advantage plans. We wonder why, you may wonder why Medicare Advantage plans have both enhanced benefits and an additional premium. But still, what makes it sing? Well, Medicare Advantage plans feel that they can get economies of scale, efficiency, and as a result, they may even give some enhanced benefits to their consumer. Silver sneakers. The key point that we see, though, is this process that's been around since 2006 gives logic of why this is occurring. This whole bidding process of the Medicare Advantage plans is where the plan, in essence, has to bid to offer Part A and B coverage, and it's looking at the Part D, the drugs, and they're handled separately for Medicare beneficiaries. The concept here is basically we need And when we look at it, the bid to include the plan's administrative costs and profit and take into account of it. Now, if the bid is below the CMS established benchmark, then the managed care plan can lower the cost to receive services or enhance the services. Pretty cool. If the bid is above the benchmark, then the plan usually will charge the enrollees an additional premium, not as many bells, just to be competitive. And this whole CMS HCC model adjusts the payments for beneficiaries enrolled in the plan to reflect basically their group. But ACA has changed how the benchmarks are determined. It lowered the share that a plan gets to keep when its bid is below the benchmark. As a result, not as many frills as there were years ago. But that is why some Medicare Advantage plans historically offered bells, some still do, and the whistles are there, but it also, what's happening now, it's made to share a percentage of the function of the plan's quality rating, and if they charged a lower rate, basically below the benchmark, they also have to face reality. Did they have an adverse healthy, at the inverse of an adverse bad group, a healthy group, to some degree that they might even have to subsidize the unhealthy group down the block?